Hello and welcome, everyone. Thank you so much for joining us. We're so thrilled you're here for our town hall. We'll give everyone a moment to get in and get settled. If you want to go ahead and jump in the chat and let us know where you're joining from, we would love to hear where you're coming from this evening. I'm Amanda and I'm with the IOCDF. I'm so thrilled to be joining you all here from Boston, where the IOCDF is headquartered. Of course, I'm not at headquarters right now, but we are located in Boston and I am in this area. So we're starting to transition to some nice fall weather here, finally. I'm so excited to have my guests here with me, and I'll get to introducing them in a moment, but we're just going to give everyone a moment to join and to get settled. Feel free to use that comment section just to let us know where you're joining from, and we'll say hello to everyone in just a few minutes. Thank you so much for being here. Hi, Maya. Hey, from Florida. Hope you're staying safe there, that you're in a good area. My Florida family is in the process of driving. They're evacuating. My nephews are 4 and 2, and they've been in the car for 5 hours. So it's been eventful. Oh. So hello from Brooklyn. Thank you for joining us. I actually see that quite a few people have joined already, so we can go ahead and get started with our announcements. We just have a few little housekeeping announcements to take care of, so just bear with me for one moment. This live stream is educational and is not intended to replace therapy. For treatment-related questions, please work with your provider or contact a local clinician. You can use the IOCDF's online resource directory at iocdf.org/find-help to locate a trained clinician near you. The International OCD Foundation is not a crisis hotline. If you are in crisis or you are ever feeling suicidal or unsafe, please call the 988 Suicide and Crisis Lifeline by dialing 988. You can also access online at 988lifeline.org or go to your local emergency room or call 911. We want to create a safe space and be kind and respectful to everyone. At the end of the day, we're all here to support one another. A note that this is being broadcast on several social media platforms and is being recorded. Nice to see you all. Thanks for joining. I see some north of Boston area. Hello from Cape Town. Gail, I'm glad you made it. My name is Amanda and I'm with the IOCDF. I'm thrilled to have you all here tonight, and I'm going to go ahead and get started by introducing our amazing panelists. I'm so excited to be here tonight with these incredible folks. I'll start by introducing Elise. Elise Petronzio has been a mental health advocate since she was 18. She founded and runs the OCDiapus, an OCD and anxiety recovery shop, known for their charitable pink elephant stuffed animals that help kids with OCD. She was diagnosed with PANDAS at age 25 after 15 plus years of living with it, and it changed her life. Her current advocacy passion is the intersection between OCD, chronic illness, PANDAS, and immune dysfunction in adults. You can find her online at the OCDiapus or at Adults with PANS. Sheilah M. Gauch is the principal and clinical director of Dearborn Academy, a therapeutic day school that services students with social and emotional and learning needs. She's a licensed independent clinical social worker, an educator with 20 years experience working and advocating for students with complicated mental health needs. In addition to her work with students, Sheilah engages with caregivers, educators, and mental health professionals through consultation, training, and public speaking. Sheilah has 2 children who were ultimately diagnosed with PANDAS. She co-founded the Massachusetts Coalition for PANDAS legislation, which successfully championed the passage of both an insurance mandate and established permanent DPH PANDAS Advisory Council, where she serves as co-chair. Sheilah received the 2020 Commonwealth Heroine Award and was recently awarded Boston College School of Social Work Distinguished Alumni Award for 2024. Congratulations. That's very exciting. And finally, last but not least, we have Dr. Angela Tang. Angela Tang, MD, is an internist at Southern California. She is a parent of a now grown son with PANS and volunteers for the Stanford Immune Behavioral Health Clinic. Thank you all so much for being here tonight.
Thanks for having us.
We're so thrilled to have you. The foundation is so grateful that you're here, especially with tomorrow being PANDAS Awareness Day. We're just so grateful we could mark this occasion and have this really important conversation. Something that stood out to me as I was reading your bios is just the personal connection that each of you has. And so I was hoping we could start off there and just talk about why this is so meaningful to you, why you're a part of this conversation. And Elise, I was hoping you could kick us off.
Yeah, sure. So like I said in my bio, I was diagnosed with PANDAS at 25. I had it at least by the time I was 9. And I knew it was I knew I had OCD much earlier than 25. Probably like in my teens is when I figured it out. But I also developed multiple chronic illnesses, like physical chronic illnesses, in addition to the OCD, and I developed more mental illnesses. And so it really was just kind of declining steadily until I got the PANDAS diagnosis. And then with that treatment, I've had improvement across the board with my health. So I just really feel for people with OCD, especially people with OCD and chronic illness who don't realize that this could be an underlying problem, because it really affects your recovery. It's not really comprehensive without intervention in all areas. So that's why I like to speak about it.
It's amazing. Thank you. We're so grateful that you're lending your voice to this conversation. Sheilah, I'd love to jump to you.
Sure. So I have 2 children who were initially diagnosed with mental health issues. They had their onsets at 5 and 7, and it took years of kind of cycling through therapy, different medications, and they weren't actually getting better. They were actually getting worse. And it was by the time one of my children was really very acute, and really nothing else was working. And I kind of was trying to figure out, I'm a social worker by my initial training. So really, I kind of knew all of the tools that I had in my toolbox, and I was really leaning into other professionals and try to getting them help. And they were really presenting, actually both children presented really differently, which was also really interesting. But they had really significant OCD, ADHD, sensory issues, and like things just kept getting worse and worse. And finally, we were able to find the PANDAS diagnosis really kind of just in time, to be honest, because one of my children was so sick. And as a social worker, I watched them heal in ways that I had never seen before, truthfully. And I felt like I was handed a puzzle piece that I knew I needed to kind of run after and understand more, to see like, who else have we missed? If my kids have been missed for most of their childhood, and they really got to be afforded a lot of healing and recovery just using a different tool in our toolbox, along with all the other mental health tools we have as well.
Wow. What an incredible journey you've been on. Thank you for sharing that. Dr. Tang?
Wow, some of the things that you guys have said really resonate with me so deeply, I can't even tell you. But basically, my story is I'm trained in internal medicine, so I'm not in any field that is directly relevant to this, at least not to date. Maybe it should be in the future. We'll change that. But I had not been taught about this illness in medical school. It hadn't even been described by the time I graduated. So, I'll use that as my excuse for my ignorance. But my son was in high school at the age of 15 when he suddenly got weird. It started with being weird, and then it turned into very obvious OCD and his asking for our help. And I was like, okay, well, so he's got OCD. I know what to do with that. It's cognitive behavioral therapy. And, maybe we'll find a therapist if we can't deal with this ourselves. But it very, very quickly steamrolled our family and just took everything out of us. So luckily, our pediatrician had heard of this and mentioned it to us. And long story short, because we are connected with a whole medical community, a second pediatrician mentioned it. And that's when I really started to say, I got to look into this diagnosis. And once I looked it up online, which, most people diagnose themselves, I think, unfortunately, still. I said, oh my gosh, he meets everything here except for like one of the whatever criteria. Like he's missing one thing, but he's got everything else. And except that he's a little old, because it says pediatric and prepubertal, and he's really not prepubertal. So, nevertheless, I called my pediatrician, who agreed to support us with trying some antibiotics. He had had a sore throat, but it had been weeks since it passed. And with the antibiotics, he, within 4 days, was almost normal. And that's when my husband and my jaws, dropped to the floor. And like, we have never seen anything like this. So unfortunately, it didn't stick, and he wound up getting hospitalized and getting his definitive treatment, which we can talk about. But when you're a physician with this sort of a really desperate illness, with experience in this desperate illness, and people find out about you, they tend to reach out to you and, can you help me? What should I do next? Who should I see? And so it feels much like a rabbit hole when you get this entering your family, that you fall into this deep rabbit hole and you can't come out because more and more people just keep needing you and you want to help them. And, basically, helping families one at a time, very, very challenging. So I got involved in doing some of the legislative work that Sheilah did in Massachusetts, and that's been great. Yeah, I don't know. It's not something, once you've seen it and you know that you have something to give to the community, that you can turn your back on. So I think, similar to Sheilah, that's why I'm still here.
Yeah, can I add one thing? I just jumping off what you said, Angela. And just kind of how your jaw dropped, when you saw it. I think for me, I heard about it 6 years before I went looking for it. I'm still kind of ashamed of that, to be honest, because as a social worker, when I first heard it, and it was just a pediatrician who literally followed me out when my son was, I think he was 5, followed me out into the waiting room and whispered it to me. And I said, I don't know what you're talking about. Like, I know what this is. I'm a social worker. Like, I got this. Like, thank you. Like, I know what these mental health challenges are. And I didn't have it, truthfully. And so, but I think it's so hard. It's so hard to be a professional and realize, like, I might have been able to help sooner had I been open to it. So I think that's, to your point, Angela, I think that's why we keep doing this work, because we saw something that, for me, I was so surprised that they healed so much. It was
truly. And, when you're like, oh my gosh, I think I have my diagnosis now. And then you dig a little deeper online and you dig a little deeper and you realize that the entire medical establishment is not necessarily with you on this, but you have just witnessed something with your own eyes that is just so just obvious, right?
Yeah.
It was hard enough for us, but like, if it was that hard for us, how is this for everybody else? And that's when you realize that you have to do something to help. And I also realized, you talk about sort of the guilt of being the parent who maybe could have intervened sooner. I have an additional layer of guilt. Well, I'll go into confessional now. But I know that had I not seen this with my own eyes, I would have been one of those skeptics, right? Because it looks strange and weird. Like, why on earth would an antibiotic have done that to my son, made him better in the absence of an obvious active infection? So I thought to myself, maybe I have a role to play. I'm a physician. I've got some credentials. I've seen it. I've lived it. I think I speak pretty clearly. Maybe I can help explain this illness to other people who don't understand, or maybe who wouldn't believe it just reading it on paper, because it's really weird.
Well, we're so grateful that you are out here advocating like this. And you mentioned, the on paper definition, and I'd love to just backtrack a little. And just for those who are joining us, we have a lot of regulars in the audience who may have stumbled upon this and have not had a ton of education around the subject. Could we just backtrack a little bit and define for folks what PANS and PANDAS are, what the acronym is? I should have written it out for us.
I can start with that, and then maybe Sheilah can run with the ball. But it's so PANDAS was the first thing described, and it stands for Pediatric Autoimmune Neuropsychiatric Disorder Associated with Streptococcus. Strep as in strep throat, the bacteria that causes strep throat. And PANS is a term that was added later because it started to be recognized that sometimes it was hard to identify the strep, or maybe it had a different trigger that was not strep. And so that acronym is Pediatric Acute Onset Neuropsychiatric Syndrome. And basically, if you kind of decipher all those letters, you do get to the gist of the disease, which tends to have onset in children. Acute onset or autoimmune, it comes really fast. and sort of takes over. It's felt to be immunologic in origin, where a child will have some sort of an immunologic trigger. Most often it's strep or strep throat. And in the body's attempt to eradicate the infection, the body will make antibodies. Unfortunately, it's felt that some of these antibodies will cross-react with brain tissue. And then the certain areas of the brain that get impacted cause a very characteristic set of symptoms. And I'm going to pass it to Sheilah and Elise to talk.
So I would say a lot of us kind of in the advocacy community, and I know that they're looking at kind of the diagnostic criteria. Some of the PANDAS Physicians Network are kind of the leading experts. They have it's called the JCAP, the Journal of Child and Adolescent Psychopharmacology, right, Angela? Which is basically their diagnostic criteria and their treatment guidelines that they've put together. But it is an acute onset or a sudden worsening of either OCD. And the way I like to describe the OCD is it can be really kind of traditional looking OCD. A lot of the students and children that I've worked with kind of have really sneaky OCD. It's kind of that perseverative looping thinking. And often the compulsions are maybe reassurance seeking. They're having really intrusive thoughts and they're having that real perseverative thought process that can look really obsessional, and the compulsions might be really sneaky. So it's either OCD and or eating disordered behavior and eating restriction. So ARFID, anorexia. Anytime I hear about students that are, or children, sorry, I work in a school, so I say students all the time. Children who aren't spitting or swallowing, fear of choking, fear of vomiting. Like a lot of times, like I kind of wonder about that with the eating pieces, because I've seen a lot of children be later diagnosed. So it's either OCD or an eating disorder. And then there are 7 other categories of that you have to have 2 of. So it's either like it's emotional ability, depression, behavioral changes, sleep disturbances, enuresis, bedwetting. And so I think I would also just say that there are lots of potential triggers out there. Like COVID comes with about 30% neuropsychiatric symptoms. So COVID, the flu, mono, there are lots of different triggers for PANS. Lyme, sorry, Elise, yep, Lyme.
I'm like, that's mine, so
Yeah,
gotta represent. And then, so I guess for me in these kinds of conversations, I like to lend my personal experience, because for years I heard about PANDAS from like, you know, what it looks like on paper. But for me, it would have been more helpful to hear what the actual onset looked like in some people. I know Angela talked a little about her son, but for me, I had a sudden worsening of my OCD. I had some OCD tendencies before, but I can remember like the exact week of my life. I woke up and suddenly I had a very debilitating fear of throwing up, emetophobia. And then I just started doing more and more compulsions in the weeks that followed. But there was like it was in July 2006. I was on vacation. Like there was a very set, for me, it was like an overnight switch where that I like plunged into OCD, severe separation anxiety, sleep disturbance, and that would have been it. That's all I would have needed for the diagnosis, is those 3 things. But I did not see anyone that knew about PANDAS, so I did not get the diagnosis. I also did not get an OCD diagnosis either. But yeah, so 2006 was not a good time to have these illnesses.
Now, I can tell you what it looked like as a parent from the outside. And I think it's important to emphasize that it looks really different depending upon what age the onset is, because a 3-year-old or a 4-year-old who gets this might not have the words to explain to you. They might just tantrum. They might run. They might hit. They might destroy their classroom. My son was 15, very intelligent. And what it looked like from my point of view was he got kind of anxious. And then I started noticing that he was lining things up in groups of 5, and that the shampoo bottle was just so all the time. And these perfectly sharpened pencils were always on the edge of this desk at this precise angle, lined up, brand new, never used. And I would go by and I would kind of push them a little bit just to kind of make them go out of order. And the next time I'd walk by that darn desk, he'd put them back. I'm like, okay, this is getting really weird. And then he couldn't sleep at night, and he needed us to sleep in bed next to him to fall asleep. Then he started spitting, and he started having intrusive thoughts about everything. I mean, it started because he's a good student and he worried about his grades. I think it sticks to whatever you care about most. So it started as an academic OCD where he was nervous that he couldn't get through his classes. He couldn't write the letters D and F, so he'd have to compose entire English essays lacking those letters. And then he couldn't use the letter C either. And you can kind of see why, but he had to use a lot of the letter A. Sort of funny, except that it wasn't. So he would spend all this time, with the first sentence of an essay. Lots of perfectionism, lots of tearing up the paper, lots of contamination fears. And in response to that, he would spit or wash his hands endlessly. This occupied 97% of his waking hours. He stopped being able to eat, stopped being able to drink. He couldn't walk a straight line because he would see imperfections on the ground and he'd have to do these circuitous routes. It took him 45 minutes to get home from the bus stop 2 blocks from home. And that was the last time he went to school until he got better. He's not religious, but he developed a sort of scrupulosity, if you will. That's what the professionals call it. But he had to pray, and they had to be sets of 5 and had to be perfect. And if they weren't perfect, he'd have to start over again. And he couldn't get out of the shower until they were done. And so he'd be in the shower until the water ran out, and I would literally have to pull him out. This was extremely time consuming, as you can imagine. And when I thought he just had regular OCD, I bought a book on Amazon and I said, look, hon, this is what we're supposed to do. Read this book. You're smart. This is what you're supposed to do to therapy yourself out of it. And he started reading all the different kinds of OCD, and he got to the hoarding OCD. And I please don't, nobody out there, if you have this, don't take it personally, but he had read through every other type of OCD. And when he got to hoarding, he started laughing. He said, oh, this is so weird. I'm like, sweetheart, everything on this list is weird. I'm like, everything you have is really weird. You have all of it. That's what it looked like from our point of view. And when he stopped being able to eat or drink at all, and he started to get dehydrated, was, basically what triggered us to go to emergency rooms and ultimately to be admitted to the hospital. All within a period of 7 weeks from onset. So it's like a lot of people will remember they'll wake up with it, or they'll be at Disneyland and it'll strike them there. Like they'll remember, it's like, who shot, where were you when JFK was shot? Like, where were you when your parents hit you?
Yeah. And I think the interesting part is for a lot of families that I've worked with that we found it later, you kind of make up a different story. And like for us, we made up different stories with our kids. Our onset was actually at Disney World, unfortunately. But my other child, my younger child, like we made up a story because that's what we do as humans when we don't understand what's happening is, when they were 5 and they had their onset, the story was their older sibling was sick. Right. And so it must be PTSD and it must be trauma. And yet they also had an abrupt onset. And I think we often as parents kind of miss the onset because whether it's the terrible 2s or the terrible 3s, or it's something about age 4, or like we have kind of these developmental milestones and we kind of fold it in and children don't have the language and they often will not share their intrusive thinking because they know it's strange. It's almost like they know I often say they know it's like incongruent, maybe if they live in a safe home and they're having these really unsafe thoughts, it's confusing and they know not to say it because they feel a lot of shame about it. But if you start asking, like I've done it at the school I'm at, and I'll say like, are you having these really sneaky thoughts? And I'll have students say like, are you a witch? Like, how do you know that? I'm like, no, it's just, so I think we just have different narratives about things and and sometimes you miss it.
The brain broke narrative is really common in the OCD community. I hear it a lot. I see it in social media posts. So I just want to be very clear that would be an abrupt onset. And for me, that's like, I immediately think of PANDAS. So if you hear that as a therapist, peer support, you're hearing it in your like your friend's story, that's like really normalized, and that connection is really important for me for people to make, because I thought for many years that I didn't have PANDAS because I don't have a big history with strep. But like when you look back now, I'm like, I had the overnight onset. Like that's a huge flag for that. But yeah, so just wanted
I
to add
think,
that.
yeah, I think that self-awareness that your brain is broken was something that was helpful to me. When my son got so severe, I was like, gosh, is he having a schizophrenic break? And I thought, no, because schizophrenics really believe in these, whatever their delusion is. It's a true belief. My son knows that this thing isn't contaminated. He knows this isn't real, but he can't help himself. So there's a difference there, I think. And to Sheilah's point, what we're seeing is that actually a lot of kids with PANS have a prodrome too. So there's something little. If you really dig hard into their past history, you go through their pediatrician's notes all the way back, you might find something that could have been a little mini pre-PANS episode. It wouldn't have met criteria, but it's a little something, like a little touch of OCD in the past that maybe came for a while and then it kind of went away, or maybe a flurry of tics. Not all tics are PANS, but maybe something happened and and they were kind of acting weird at the time too. In my son's case, in 7th grade, we got called in for teacher parent conferences because he was acting up in school. He was like really squirrely, disruptive, kind of inattentive. He got fired by his piano teacher because he couldn't sit still. And he was fidgety during his 1-hour lesson, and he'd get up and pee like 3 times during the lesson. And at the time, I was really pissed because that lesson was $1 a minute. So he was going to the bathroom, and I'm like, sit down. But really, I think it was the urinary symptoms of PANS that he had in 7th grade. And he wound up getting diagnosed with severe ADHD by a very expensive psych educational assessment that we private paid for. And he refused to take any medications or do anything about it. He just refused. And over the course of a year, it went away. So at the time, you're trying to go figure out, why is this happening? Oh, it's 7th grade. He's just in middle school. It's adolescence. It's just this. It's just that. Maybe there's bullying. There's a reason for it. We try to explain it away as human beings, try to find attribution. And in retrospect, it may have been pre-PANS. I don't know. It was something that went away entirely. And then it was like, oh, no, his ADHD is cured. He doesn't have it anymore. I'm like, that's not how it works.
I have those too. That's why I'm just thinking, like, we thought it was normal that I had to keep extra pairs of clothes in the nurse's office because I had that many accidents, like that frequently. And we were like, she's just like, young for her age, because I was right before the cutoff, and my parents were like, she just needs to like get a hang on buttons. And now I realized that a couple days ago and texted Sheilah, and I was like, oh my God, that's the urinary stuff. Yeah.
Right. But like, what are you going to do about it? Right. So even if I could go back in time, he didn't make PANS criteria. There's nobody that would have treated him as PANS. And we're not saying that every little girl who's in 2nd grade and peeing her pants should hurry and get assessed for this, because it's not the case. But it's interesting that I think, we call this acute onset. And so when we were getting diagnosed, people would say, oh, do you have any of this in the past, any mental health history? And we're like, no. And only when I really sat and thought about it, I think a lot of practitioners will say, oh, well, they've got this past history of ADHD, autism, whatever, behavioral stuff. Therefore, it can't be PANS. It's just a worsening of their A, B, C, whatever. But I think we have to remember that it's a relapsing remitting disease. And there's a lot of immune diseases out there, or psychiatric diseases out there, that do have a prodrome. Schizophrenia, for example, very clear. So I think that having little hints of this in the past doesn't rule out that you have PANS when you have your major deterioration happen.
I'd love to dig in a little bit, because it sounds so complicated, the diagnostic criteria and how this manifests itself. And then it seems like it's really challenging to diagnose as well. So I'd love to talk a little bit about that.
So I don't think the diagnostic criteria is super complicated. I think it sounds it when we start talking about it, because it's really just either OCD or an eating disorder, or and then two out of the 7 other criteria.
Do you want to pull it up? Do you want to pull it
Yeah,
up?
let's pull
Yeah,
it
that
up.
would be, if you have it, I think it would probably be helpful.
All right. So this is the article that it comes from. It's a 2015 publication. Let me see if I can figure out how to, aha. Okay. And inside the publication, it's a consensus statement, right? So this is basically all of the people who had a lot of expertise in 2013 to 2015. They got together and they had a meeting. I think they met in Palo Alto. It was led by Stanford, but there were people from Mass General and really all over the country with experience. And they sat down and said, what are you seeing? What are you seeing? I don't know. What are you seeing? Do you see this? I see that. Do you see this? And decided together on the commonalities for this syndrome that they were seeing. And, it's a clinical diagnosis, so there is no lab test, right? So although there's an association with strep, you don't necessarily have to have that positive throat culture. Most of the time, any strep throat's long gone by the time, they make it to your office. So
and
here's
it's not
what
just to say.
And it's not just strep. It's not just strep. It's
not, no.
more strep than anything else, but it can be other things. And a lot of times you'll never know what it was, especially if, for example, in Elise's case, it was far, far, far in the past.
Yeah, because you get more and more triggers. Like I have a ton of things that could be the trigger. I just know Lyme is a big issue for me now. But when you have one thing like Lyme making you more susceptible to picking up different stuff, then suddenly you have like 5 different things that could have been the trigger, but you'll never know which was first.
Right. And what we do know that once you kind of establish this inflammatory pattern in a patient, student, child, however you want to call them, then a lot of things can cause a flare, right? So we don't think, for example, that the common cold can be the original trigger. But once a kid has this, when they do have a common cold, they tend to, their symptoms will bounce a little bit and come back a little bit. It can trigger a flare. So just this is basically the list that we already verbally went over, but you have to have in Roman numeral number 1, either abrupt dramatic OCD or severely restricted food intake, one or the other. Okay, so that's the cardinal symptoms. And then the Roman numeral is you have to have at least 2 out of this list of 7 symptoms. I kind of went over them. And I'll say that the average child has more than 5. So we're not talking usually about a subtle disease. This is usually more of it took over your life kind of thing. One thing that we haven't mentioned is the handwriting. So where is that on here? There's school performance issues, sensory and motor abnormalities. All of these things oftentimes contribute to a real bad deterioration in handwriting with certain characteristic features. But if you look at my son's, he actually stopped being able to write at all. But when he could write a little bit, it looked very barely legible, lots of scratch outs, lots of erasures, and just kind of real primitive looking. So there were many months that he needed a scribe.
I think, Amanda, what you're probably hearing from us is how complicated the presentation, it can present in so many different ways. So it can present as mild, moderate, or severe. So, and it can also, it's impacting the basal ganglia in the brain, which is the house of movement, and it kind of radiates out to the rest of the brain, right? So everyone has different presentations based on how their brain is impacted. So I had 2 children who had completely different reactions. They both had OCD, but the OCD presented differently. In one, it was more acting out, and one, it was more internalized, so because it's brain inflammation, and in every person it presents differently. That's probably why it feels a little bit more complicated when you hear about it, because it can be, in every person, it's a different set of issues, if that makes sense.
No, that makes sense. Thank you so much for providing that clarity. That's really helpful. I wanted to remind our folks in the chat that we are welcoming questions as well from you all. You don't just have to listen to my questions. You can contribute your own to the conversation. So please feel free to use that chat window and drop questions in the chat. We'll try to get to as many as we can. Elise, I saw you start to pipe up before I chimed in, so I'd love to hear what you had to say.
Yeah, I just wanted to kind of add, like, I know Angela said that it does tend to be very intense, and my OCD onset was very intense and life altering for me. I do think a lot of the stuff I'm going to be saying is more from just being in the OCD community and listening. Like, I've been to a bunch of conferences long before I knew I had PANS. And a lot of stuff is like really normalized, I feel like, in the OCD community as like everything being written off to OCD. So like it took me years to pursue the PANS diagnosis, even though I clearly had like the criteria for it, and then I had the complications that many people who don't get treated for it have. But when you think about it, I mean, it's people with OCD think rigidly. I do. But it doesn't have to be like a perfect picture, like Sheilah was saying, of like exactly like the 5. And I know this isn't what Angela was saying either, but it doesn't have to be that you have like all 5, or like emetophobia counts as eating restriction, which I never saw it that way when I like read the criteria, but I stopped eating because I was afraid it would make me throw up. So I'm just kind of piping in to urge people to like, it's like if you have a general sense reading the criteria that a lot of these things have happened, then I would possibly look into it. Like, I just waited because I feel like I saw other people talking about having seizures and dystonia where like their hand would like cramp up, or rages and screaming. And it also goes back to what Angela said about the age differences, because my PANS flares as I got older did become much more about intrusive thoughts and less about like more physical compulsions and about separation anxiety to my mom. So like it's much more flexible than it seems. So I just kind of wanted to point that out because I feel like there's a very rigid view of what it looks like to have PANDAS, and I waited multiple extra years because I didn't think I fit that picture.
Elise, I'm curious about your take on this, but to me, it seems like the kids have a certain flavor, and it's really sort of an anxiety flavor, right? Like it's driven by this, it's OCD. OCD is basically an anxiety type of disorder, but they get into this sort of fight or flight, and I think that drives a lot of the rages and the flight. I mean, some kids will run for hours. Better hope your kid's not fast. I've heard of like track players running. I'm like, oh, track athletes. I'm like, no. Then the parents chasing them in a car down the street. So, did you feel like that was the basis of your symptoms? Did you have a great deal of anxiety or fight or flight?
Yeah. So the way I describe it, when that first huge flare happened, and every flare I had since, it feels like the entire world just goes wrong in like a very short amount of time. Like just being alive was like anxiety provoking. Like everything felt, the like aura of the air felt wrong. Like I don't know how else to explain it, but it was like everything is wrong. Like I'm standing in the wrong spot. This person's saying the wrong thing to me. Like you can't find comfort. That's how I felt. Like I just was like paralyzed with anxiety that had no real rational thing that it was tied to. Yeah, that was like the more intense parts of my PANS would feel like that. But then I would have just kind of like more mild OCD in the interim between when they would randomly flare up and become severe again.
Right. Yeah, but I think that you talk about like some kids have a lot of neurologic symptoms, and they have odd things like these sort of pseudo seizures or dystonia or just wild tics, and I think that speaks to the pathways of the brain that are involved. But it's not like that for everybody. My child was much more logical. He was older, so he didn't have the rages and the flight. Mm-hmm. But I think had we let it go a few more weeks, he might have. So yeah. The one thing I should point out is on that one slide where we showed the criteria, the third Roman numeral is symptoms not better explained by known neurologic or medical disorders such as Sydenham's chorea. So you always want to make sure that you're not actually dealing with a case where somebody is getting bullied or abused, or or it's actually neurolupus or some other medical condition causing this. So just to make it a little more challenging.
You're on mute.
Oh, Amanda, you're on mute.
Thank you. I'm sorry. I'm usually better at that. I'd love to jump into one of the questions we got from the audience. This is from Jake Winchester, who is tuning in. Jake asked specifically about cases like yours, Elise, where the diagnosis is missed in childhood but found later on. What resources are available in that situation?
Yeah. So it's a bit, I'm like, I want to put a positive spin on it, but it's a bit of a bumpy ride if you're an adult. There are less providers. There's already not a ton of PANDAS literate providers. And on top of that, some of them, a decent amount of them will not treat adults at all. But once you can get into some sort of provider that treats adults, I mean, I've had more progress than I ever would have thought. That was another reason I didn't pursue the diagnosis, is I had the idea that PANDAS was like a one-time event that gives you OCD, and then that's like the end of it, which is not true at all. So for me, like it's a lot about treating what your triggers are. So for me, I've had to do a lot of different treatments for Lyme disease because that is something that is still impacting my immune system a lot, which anything that's impacting your immune system could be causing it to do that cross-reacting that Angela was talking about. But yeah, so there are a few different organizations. Someone in the chat actually was just talking about Aspire has a provider list. I think PANDAS Physician Network has a provider list as well, maybe. But and you can find out if they treat adults. But it can still be treated. It's just usually more complicated, more expensive, because it's very hard to find in-network providers, people that take insurance. Yeah. Anyone else want to add on to that?
I think that's honestly why, Amanda, we're so grateful IOCDF had us on, because I think it's so important to raise awareness so that we can get the message out so that people can get diagnosed earlier, because it does get harder. I mean, truthfully, this illness isn't equitable. I kind of I talk a lot about that, how we don't have enough resources. We don't have enough awareness around it. But there are, at least just mentioned, there are adult providers. And it also happens, PANDAS does not have an age restriction. So you could have acute onset after COVID. As a young adult, that has certainly happened. I'm a board member of the Alex Manful Fund, and Alex lost her life to PANS at 26, and she had a later onset. So I think it's also, it can, in Elise's case, it started in childhood for sure and was missed, unfortunately. So there's also a lot of research, and Angela can probably speak to it better, that if you catch it early, it's quite frankly easier to treat. And that's why we kind of love these opportunities to spread awareness more. But it definitely can happen later on as well for a trigger.
We've been working for years now trying to increase awareness amongst the pediatric clinicians. And I think really the next step will be to increase awareness among internists like myself, and to create a pool of providers for these kids that are all now growing up, and, who will take care of them, who will take care of my son. Luckily he has me, but it's really, really hard as an adult, in answer to that question, to find somebody to help you. That being said, there's a whole burgeoning field of neuroimmunology or neurorheumatology, or, kind of combine these fields, these interdisciplinary medical specialists who are really interested in how the immune system affects behavior and the brain. So I think it is improving. I know that there are some people interested in this at various university centers. Mm-hmm. It's a long fight to get your insurance to let you go there. So keep trying is my best advice to anybody who's in that situation. I do want to point out too that I don't know if we're giving the impression that this, Elise said, like, you got the impression this disease just sort of comes on and that's how you're left. But it's not. It's almost entirely a relapsing remitting disease. So like you'll go through this phase of, the average flare lasts maybe about 12 weeks, but there's a lot of variation there. and then it'll kind of go away, and then you'll have this period where the person's doing quite well, and then boom, it'll hit again. The onset is very steep. The offset is much more gradual. So that's something that I think people should be aware of.
Yeah,
Yeah,
no, I was just gonna say, I also wanted to touch on that it's not like I spent the whole 15 years between, or 15 plus years from when I would have had the onset to now, like in my house not going anywhere. It was like the OCD would fluctuate very much in severity. It'd go from mild to severe like overnight, but I would have like months at a time where I was like pretty fine, but then I'd hold on for dear life during the flares, and then over a couple months, like 2 months, they would go down. But yeah, so that's the other thing too. I feel like people expect you to be like completely not functional in order to have it, and that's definitely not true. I graduated like top of my class in college while I was still having PANS flares, so it varies a lot.
I think there's a piece for the mental health providers out there that might be watching. For myself as a mental health provider, I've definitely I've had children that in my advocacy, I've seen children who have been diagnosed with PANS, and then they have another flare of symptoms. So they probably got another virus. It's not intuitive for us as mental health providers to think like, oh, maybe they have PANS. Maybe that flare up of OCD is actually a secondary infection. Like they got strep again, or they got mycoplasma again, or which is like bronchitis. And so what happens is sometimes people say, well, they already treated PANS, it's over. And then the child collects other diagnosis. They get a bipolar diagnosis. I've heard children who've gotten borderline personality, like things. And what you've missed is it's actually the PANS. It's just a flare up of symptoms. So it's understanding PANS doesn't just go away. It's either an autoinflammatory and autoimmune kind of issue that's impacting the body. And with subsequent illnesses, you will have flare up of symptoms. It's not a new mental health diagnosis per se. It may present as having symptoms such as bipolar or depression, and it's still PANS at its root. Does that make sense?
I feel like a kid at school. Ooh, I have something to say. So I've seen these questions come through the chat about like what other conditions are associated with this? Can we address the narrative that this just goes away with antibiotics? Can we talk about chronicity? So I think that's really important. I think that more and more we are realizing that this is a systemic chronic illness. And there's going to be a lot of people who don't want to hear this. But it's a systemic dysregulation of the immune system. There's something up with this immune system in this person. It's a little overactive, or maybe it doesn't know how to turn off at the right times, whereas other people know how to turn it on and turn it off. With the infection's gone, I'm going to calm down now. Or there's something up. And what we're finding, if you look at Stanford put out a couple great papers recently. The first one last year was actually, I think, first author on both is Dr. May Ma, so you can look them up. But Dr. Ma published that a significant percentage of the kids that are being followed in the PANS clinic go on to get a diagnosis of arthritis. And not just like achy joints, but actual, I can see it on ultrasound. There's evidence there. I see, fluid and things that are not supposed to be there. Inflammation around these joints and around the insertions of the tendons and the entheses around the joint. And then there's a follow-up paper just a few months ago looking at second autoimmune diseases that happen in these children if you follow them long enough. So you've got this kid who has PANS, and you may treat with antibiotics or NSAIDs or whatever you do, and you may squash that flare, and you may pat yourself on the back, but it's not over yet. You need to continue to follow this child. They are at increased risk for additional autoimmune diseases happening. And not only that, okay, so I guess there is a small silver lining to this, which is if you do find the arthritis, then that gives you a target to treat and to follow. Because it's really hard when the primary symptoms are behavioral. How do I know when I'm exactly out? Like, it's hard to know how hard do I treat, how long do I treat? But if you can find joint symptoms, then suddenly this opens up a whole realm of standard of care medicines that have been used for decades in pediatric arthritis. Or if the child goes on to develop inflammatory bowel disease, then you have those treatments available to you that are used, the immune modulators for inflammatory bowel disease. And the sense is that if you can treat these, if you find any inflammation going on like that and you treat that, the PANDAS will often quiet as well in parallel. So yeah, it's not quite as simple as just give antibiotics and have it, be done with it. You do need to follow.
Well, and I think it kind of calls for a real mindset shift. I know for myself, when my children started to get treated, when we had antibiotics, anti-inflammatories on board, the improvement was so stunning that I thought maybe it was over. And then we'd have another flare, but we'd miss. I would have missed, because by the time we caught them, they had been missed for so long. Their immune systems were pretty dysregulated. So they weren't throwing off they didn't have fevers. They didn't actually look sick. Like, I would have told you my kids were the healthiest children in the world, to be honest. And I know at one point, one of them started to have really self-harm, intrusive thoughts really significantly. And my training as a mental health provider made it challenging, because my first thought was, okay, I'm going to go back. I'm going to get the CBT on board. I'm going to get it. Something's happening. There must be a trigger that caused this increase in kind of these thoughts, right? And turns out, like, I had to almost retrain my brain. And the pediatrician said, like, we have to get lab work. Like, we have to see what's going on. And that child had a raging mycoplasma infection. They actually had bronchitis, but their body had been so sick for so long, they weren't showing signs of an infection. So when we treated the infection, those thoughts went away. So it's almost like you have to kind of retrain your brain to think like, I'm going to go back to the doctor, as opposed to I'm going to go and get another psychotropic med or therapy. You need that too. I'm not saying don't have that. But in this case, the big piece is you have to treat the infection in order to calm the symptoms first. And then you can use the psychotropic medication and therapies.
Can we show the triangle?
Yeah, please. We were all so excited about this.
This is the 2017 treatment guideline that was published again by the PANDAS Consortium, the same group with some new additions of doctors from all over the country. And they basically look at the treatment aspect as being three-pronged, that you need to address any infections present with antimicrobials, aka antibiotics, that you need to calm the immune system with immunomodulatory treatment, of which usually the first thing that is reached for is NSAIDs, so like ibuprofen or naproxen, simply because it's cheap and it's easy to get and you don't have to fight an insurance company. And oftentimes it's quite effective, especially in the early cases or the mild cases. It can really make a big difference. And then the third prong is all of the psychotherapeutic treatments, such as SSRIs, cognitive behavioral therapy, ERP, all of those things that fall in, more of Sheilah, like you have to train yourself about these to have a new approach to use the other two prongs as well. I will speak from, and you can take the triangle away, I think.
Can we keep the triangle? Sorry.
I bow down to the triangle. But from my child's point of view, okay, so there's a lot of issues with the psych part of the triangle. First of all, getting a provider to see you, because there are not enough providers, is a massive challenge. We, as physicians, had trouble getting anybody to answer our phone call, like to even return a call. When we finally did get my son into cognitive behavioral therapy, he was probably maybe 2 or 3 months, 2 months past his real turning the corner and starting to get better. He actually wound up needing IVIG. My son, the antibiotics work great, but very, very transiently. So he got IVIG. He started to very much turn the corner. And then about 2 months later, we finally got him into CBT. Somebody was willing and was a good match. But he couldn't tolerate it. Like, he literally couldn't do it. It's probably the only thing he's failed. Like, he gets an F for cognitive behavioral therapy. He basically curled up into a fetal position on the couch. And the therapist and I were looking at each other like, ooh, what do we do next? And I paid $250 an hour for that. It wasn't helpful. We tried. I think when the kids' brains are just so inflamed, it's just not always effective. So you kind of have to get to the root first, and then later on, the CBT will provide them with very useful tools to deal with the residual thoughts and to be prepared for the next flare. So they'll know how to deal with it when it starts coming back. So it is really useful. It's just not great when the kid is super hot. And the other point to make is that these children have been observed to be really, they have a lot of side effects if you give them standard doses of psych medicines. So if you're going to try an SSRI, which is sort of standard of care for OCD, if you're going to go the pharma route, you should start with a quarter of the usual starting dose for a child of that size, and very, very, very gingerly bring it up. And they have been very helpful for a lot of kids, but you just need to be very aware that they have a lot of side effects. They may or may not react the way you expect them to at first. And the last thing you want to do is try a medicine, and then the kid has some strange reaction, and then the parent's so turned off they're never going to try it again, which I think a lot of the clinicians deal with. Like, oh my God, no, we're never doing SSRIs again. Well, the bulk of the flare is over. Maybe we should try it again, but it's like a hard no because they had such a bad experience.
Could we pull the triangle back up? Yeah. So I'm like trying to remember everything that Angela said because I feel like I wanted to hit a million things, but I feel like telling what happened to me in terms of the triangle kind of outlines some of the things she just said, because I basically was like a psychotherapeutic treatment baby for the entire 15 years. Like my parents, every time I had a PANDAS flare, would put me back in therapy. And I never got immunomodulatory treatment or antimicrobial treatment. And so what happened to me too is I had OCD and it would wax and wane. I would go to ERP. The first time I went to ERP, it was fantastic. And then every time after that, I felt like it worked less and less. I felt like it wasn't doing what it used to do. Probably because I was becoming more and more inflamed as the condition progressed with no intervention for the inflammation part. Yeah, so I think it's very interesting and something that's not talked about a lot in the OCD community, the idea that ERP has like a chronological place. If you have PANDAS, it's not that it's never helpful, but I really felt I loved it when I first did it, and then as I got more and more sick, it worked like less and less. But yeah, I don't totally remember what else I was going to say about that. But I only got the psychotherapeutic part of the triangle my whole life, and that's why my immune system continued to be dysfunctional, and I continued to develop more immune-related conditions. Dysautonomia has growing evidence that it's immune-related, possibly autoimmune. That's a really big comorbidity for people with PANS, especially adults that did not get treated when they were younger, I've noticed. Chronic fatigue syndrome, Hashimoto's. I hear a lot of people with arthritis, like Angela was saying. So that's why also whenever I hear of people who have OCD and an immune-related chronic illness, like an autoimmune disease or eczema or asthma, I'm like, are you having immune issues in multiple organs? Like, could your OCD be related to PANDAS, especially if it doesn't seem to improve with ERP? Like, I know a lot of people who had done ERP and they're like, I'm not doing it right. I've been to residential 3 times and I don't know why it's not working. And I'm like, maybe it's PANDAS. I don't know. That's just, yeah, that's kind of my thing at this point.
I see a question here in the chat about, so my child now is being told that it's just damage and the PANS isn't there anymore. I think, and then they're expressing frustration. That is a really, I've been there. Yeah. That's a tough place to be because you don't know, like, are we out of it? Like, what am I dealing with? Am I just dealing with like the residual sort of damage or habits? Is it just the OCD that's gotten so ingrained? And it's hard to know. It's hard to know because my son was getting IVIG for a number of months and we didn't know when to stop. I mean, it was clearly getting better, but then his trajectory slowed down. And do we keep going? Do we stop? I mean, this is, what do we do at that point? I'm hoping that soon we'll have some kind of a biomarker, that it'll be simple. We'll get a blood draw and we'll say, oh, your PANS titer is high, and therefore you still have some inflammation, and therefore we need to treat it some more and a little harder and a little more aggressively. Or, oh no, the PANS titer is down, and what you're dealing with is just sort of residual behaviors. Now we're going to have to really CBT you out of this, or bring you out of this fully another way. If it's of any comfort to people, I can explain the trajectory that my son took, because it did take a long time. It took a long time. I would say he went from totally functional, straight A, wonderful in September, beginning of September, to completely not able to attend school by the end of September, to in the hospital by, I think it was October 7th. All right. So we're like 6-7 weeks into it, in the hospital, not eating, not drinking, 12% of his body weight lost, not making any urine, completely dehydrated, to IVIG. And then with each treatment, he got a bit better. He was back to school by second semester. So that's January, with some 504 accommodations, still needed a scribe. But in a month or two, he was able to write, initially just capital letters, but eventually on his own. By the end of the year, he was writing normally. He looked, for all purposes, to anybody outside the family like a normal kid. Only to his parents and his family could we see that he still had behaviors, subtle stuff. And that slowly dissipated over the next year. And I would say, and then he went to college. He developed another autoimmune disease. He ultimately went to college. And probably by year 3, almost nothing left. Just the hint, like some thoughts would cross his mind. It was a couple intrusive thoughts, but he was able to bat them away, whereas he couldn't before. He still had to do a little something. So yeah, it's taken years for really it to get that much better. He's a college student now. He's thriving. He's doing awesome. There is hope. Everybody needs to keep that hope and to know that it is possible.
Thank you for mentioning that, Angela. And I'm curious, for those who may not be familiar with it, do you mind just explaining what IVIG is?
Yeah. Okay. So IVIG is part of that immunomodulation lower corner of the triangle, one of the 3 prongs of treatment. So again, we would typically start with NSAIDs like ibuprofen or naproxen. If that doesn't work, sometimes doctors will reach for steroids like prednisone or IV Solumedrol. After that, there are other options. For example, IVIG stands for intravenous immunoglobulin. What it is it's actually a blood bank product. So when people go to the blood bank, they donate, whole blood. It's sorted out into components. Your red blood cell might go to the car crash victim, but your antibodies can be collected and pooled with antibodies from many, many donors, because it takes a lot of donors to make one bag of IVIG. So you collect all these healthy, presumably healthy antibodies from donors, and you infuse it in. And we don't really know how it works. I have a very simplistic way of thinking about it, is that I'm pouring in all this good antibody, these clean antibodies, and it's somehow flushing out the anti-brain antibodies that the child is making and diluting it out and, displacing it from the basal ganglia. But that's basically what it is. It's given intravenously through various ranges of dosages. It's weight-based. But the typical infusion would take place over 2 days, many hours one day, followed by many hours the next day. And it's very difficult to get your insurance to pay for it.
Thank you for that explanation. And I believe you already touched on this question, but I think it's a really important one to bring back up, which what Taryn is bringing up. So how do we change the narrative? It seems like we have this triangle. We know the elements that we need to be put into action. So how do we change the narrative that it just goes away with antibiotics?
Well, I think personally, we need to continue with the research. We need to continue with awareness. We need to be talking about it more. And really, I think the more we learn about it, the more people dig into it, the more we realize, the science is there. The body and brain is just connected anyway. So it just is. Like, the brain is not immune privileged. We have so many research studies coming out on just depression being linked to inflammation. And so the question around suicidality being linked to inflammation. There's so much science that's coming out, and we really need to get it out there to talk about it more. And I think the reality of the conversation doesn't just go away with antibiotics. It's just people don't understand the illness. Do you know what I mean? So I think it's like the more we talk about it, the more we normalize talking about it, we start to get some of that research. Like it takes 17 years to get bench research from the science bench to the research to a medical office. And like, we need to get it out sooner because people are sick and we need to get them help.
We really are starting to see though, that bench research come up.
Yep. 1,000%. Great.
Yeah.
Yep.
We're starting to understand on a cellular level and on a cytokine level, some of the mechanisms that are involved here. So I think, like I said, there's a lot of hope.
It really is. Yeah.
And I really think in the next handful of years, we're going to have some breakthroughs that are going to be helpful.
Yeah. And I think it's really normalizing. I mean, I think that kind of the piece that Elise was just talking about of when you have OCD and then you kind of have running parallel these kind of chronic illnesses. And at what point do we just normalize? I mean, the DSM-5 actually, the differential diagnosis is to rule out medical every time we diagnose. So at what point does it just become normalized? This isn't, this is OCD or an eating restriction, right? Like where it is a mental health issue. But what if we could use a different tool in our toolbox and people could feel relief? I mean, if we have, I think some of the numbers, I was just at IOCDF, I think some of the numbers were that, ERP, there may be 30% of people that aren't able to access ERP well. Now, there might be a variety of reasons why that is, right? But I guess if we just normalize that we're just going to do these medical rule outs and wonder about PANDAS, like we might actually find that we can really help a lot more people. The way I've really thought of it as a mental health provider, and I've reframed it because you just heard how hard it was for me to also shift my thinking, right? And understand that my children could heal differently because I was so kind of stuck in the mental health silo, right? For good reason. Like that's my whole training and my upbringing professionally. But I just think of it as if everything isn't working, and we could use a different tool in our toolbox to get someone's OCD and unremitting symptoms better, like we should try that, So maybe if we just normalize that, it's not, because it is both and. It might have medical underpinnings, just like you might take an SSRI or otherwise. And it's also mental health, and you're going to use all the tools in your toolbox for that too. So like, how do we just normalize that? And then maybe people will dig in more to the science and not, I don't know.
I see some questions in the chat about what kind of specialist you should see. And this sort of, we've tried this and who do we go to? And I think it's such a hard question to answer, and it depends a lot on where you live in the country. And somebody said it's the most important thing is that you find a PANS literate specialist. I would sort of agree with that. Just somebody who's willing to think broadly about your case, potentially try things out of the box. You get to a certain point where you're like, this person's so debilitated. Why not consider this diagnosis? Why not? Because if it gets them better, then hooray. With whatever, little antibiotics, little NSAIDs, swab their throat for strep, draw some blood tests, look for mycoplasma, whatever it takes, but why not? So, I mean, it can be a rheumatologist. It can be Stanford's led by a rheumatologist. The Mass General team consists of, they're led by psychiatry and infectious diseases. It can be neurology. It can be, your pediatrician can chase this. Immunology, allergy, another field that may be relevant. Psychiatry definitely has a role, although they typically don't like to get too deep into the medical treatments. That's a whole nother discussion about the separation of neurology and psychiatry and why they need to get back together already, get married again. It is a challenge. It is really, really challenging. And then there's DNASB questions in here about, should I check a DNASB? Well, DNASB is an antibody against strep. And it's really fairly challenging to interpret especially a one-off value. Generally, the DNase-B levels are more useful if you follow a trend of them. So if you have, for example, a kid, they have an onset of a behavioral problem, and then a month prior or two to 4 weeks prior, they had a bad sore throat, and you check the DNase-B and it's high, but you missed the boat. You can't swab their throat. You can't catch the strep in the act because it's gone already. So all you are left with is this antibody level, and you have to infer that maybe it was there. Maybe that led to the antibody level being high. So then what you would do in that case is potentially repeat it, like maybe in a month or something. And if it's come down, then that's supportive evidence, but it's not like absolute proof. It's just supportive evidence that maybe that there was strep around the time, that sore throat happened.
I think a great resource, I know that I've seen Dr. Mark Pasternak. He's a group A strep expert. He's out of MGH in Boston, and he's done a lot of great webinars and trainings for folks. And I think he always reminds people watching him that it's a clinical diagnosis. So even if there aren't high strep titers, he will treat if you have the clinical diagnosis of PANDAS. And he has found remarkable results watching people heal, even if they don't have that high DNS, however you say it.
DNase-B.
Not a doctor. Okay.
I have to say, I'm not even totally sure I like the fact that people swab throats and check titers, because I find that doctors don't always know how to interpret stuff. It's like they get the strep type, they swab the throat and it's negative, and then they tell the patient this absolutely cannot be PANDAS. That's not true. That means all it tells you is that you didn't capture the strep. First of all, throat swabs are imperfect. There's no perfect test in this world. In fact, they're kind of almost a crapshoot if it's there, whether or not you're going to pick it up on the swab. It depends so much on how aggressively you swab that throat. And these kids are so dysregulated. Do you think they're going to let you get in there and very patiently choke them with it's very difficult to get a sample. So every one of these tests needs to be interpreted. And it's a clinical diagnosis. You don't need any of these tests, but the tests can help you support the diagnosis.
Yeah,
they can help you find an alternative diagnosis, or they might help you find the trigger, which is useful, right? So it's useful in that context. It's not going to make or break your diagnosis. It's a clinical diagnosis.
I just wanted to add too, it was mentioned before, there are a couple PANDAS organizations that have directories that either you can email them, like Aspire. If you email at info@aspire.care, Gabriella True can talk to you about what options there are in your area. I think PPN has some sort of directory. I saw someone said Neuroimmune has a directory. So that's always a good place to start too. I just picked up the phone and started calling people asking if they took adults or like whatever you need.
I'm curious for supporters of those with PANDAS, so the families, what support is out there, resources are available for them? Or is that an area where we need to expand?
Yeah, I mean, I think when I give resources for families, like I'm giving a lot of the ones Elise just mentioned. There's the Neuroimmune Foundation has a great group of webinars. Some of them are free. Some of them you can pay a monthly fee and get in, and you can actually attend webinars with the experts like Dr. Frankovich, Dr. Pasternak. They give webinars for parents as well. And then so there are those types of pieces. I often give IOCDF out as a support as well, because you all have such amazing family resources for parents. But I think there are some great Facebook forums. There are some support groups online. Every state kind of often has their own cluster of supports as well. I'm on the board of the Look Foundation, which has lots of great caregiver supports. They give grants because truthfully, it's a pretty inequitable illness, and we need a lot more providers. And unfortunately, people pay a lot of money out of pocket to try to get their children and adults better. So the Look Foundation gives grants. The Alex Manful Fund, I'm also on that board, and they have great videos on their website as well. So there's lots of really amazing resources. And Aspire, I know I can see Gabriella True is on here. She's amazing. So lots of great resources, Pandas Network, Northwest Pandas. There's lots of different places. It's a pretty well-resourced advocacy community.
If you go on Instagram after this and look at my handle and look at who I'm following, it's a lot of these different organizations. So you might find the one in your region or one of the other ones we mentioned. But yeah, it's actually the opposite of what you said. Most of the resources are for caregivers and parents. There are very little resources for children, it's harder, but there's like almost no resources for adults that have it. So if you're a caregiver, it'll be much easier to find support groups and things, but we're working on the second piece.
Okay. Well, and I think part of it, truthfully, and I think it's getting better. Elise and I have had this conversation before, but there's a lot of mental health stigma. So I think it's also like figuring out how we start to develop more robustly, and how, as the adults, as my children and Angela's children are getting older, their voices are starting to be heard more. And how do we get those resources for the adults and the young adults who are really impacted, and how do we really demand it? That they really deserve healing. It's really important for sure.
We have a comment I'd like to address. There's thankful that we have providers with PANDAS background. They were saying that it's a lot of doctor's appointments and trying treatment and explaining to teachers, friends, and family, and the time off work is overwhelming. At times it feels defeating and like a marathon. Any guidance on coping through this?
I think it's,
exhaustion, doctor fatigue. I mean, I'm a doctor and I had doctor fatigue. It's like the last thing you want is to have to explain the whole darn thing again to another doctor when you're not sleeping. I mean, it's exhausting, right? And then you have to explain it all over again at the school. I will say that there are a lot of online resources, including resources to give to school personnel. So there's resources specifically that you can print out and hand to your school nurse, specifically for school counselors, on the various foundation websites, on PANDAS Network, etc.
Has great resources for that.
Yeah, and I have to say, we got so lucky because we really weren't in the thick of it for more than a few months. I can't imagine Elise having kind of gone unrecognized for 10 years. Like, what a nightmare. But just for a few months, and what I did, it was too exhausting for me to explain to like everybody. So I kept actually a Google document. I'm not necessarily recommending you do this within your comfort level, but it was like a diary of what was going on in my day, what we were dealing with, how many doctor's appointments. And I shared it with like a couple of critical people, my sister, my work colleagues who are all physicians, so they got it. So I didn't have to explain myself over and over again, but a couple of key teachers saw it. The guidance counselor, so he knew what we were going through. So when I would call up the guidance counselor, go, I need a favor. And he'd be like, done. What do you need? I didn't have to explain myself because he was following what we were doing every day. But I think that is a little atypical for people, how open you want to be about it.
Well, I think for me, it was incredibly isolating. Like, I had become so isolated from my community. I think one of the things I had to learn as the illness progressed, and they weren't getting better, and I didn't know what was happening. I mean, eventually we found PANDAS, right? But I had to learn how to ask for help. Truthfully, that was a hard skill for me to lean into. And once I did, I think, I would say to that caregiver who just asked that question, like really leaning into the other parents, other people, other supports that you can really, I think for me, just having other resources, and I feel like it's other people who have been impacted that have kind of led me through this and allowed me to get the help I need for my own children, because it's brutal. It's so exhausting, and you really need the support. And if we understand, like, partly how we regulate our nervous system as humans is actually to be in contact and have social engagement with other people. Like, we need other people. So really, finding your people and finding your kind of support groups is really important.
Thank you for that. I can't believe this, but we're actually almost out of time. So I wanted to go around and give you all a chance for some last words. I know you all have shared a lot of hope. And And I'd love to just hear, final thoughts from each of you. So I guess, Elise, if you want to start us off, I'd love to start with you.
I'm like, I don't even know. But yeah, there are a lot of resources out there. There is a lot more healing to be had if your psychotherapeutic interventions are not working as well as you hope they would, or your life is still not tolerable, whether it's your child or it's you personally. Emphasizing that if you are an adult, it does not mean you can't have this and you can't get any other relief, because there's not going to be a lot of adults to look to that have been through this process. But if anyone does want to reach out to me, you're welcome to reach out on Instagram. But this is, like Sheilah said, another tool in the toolbox. And this was a very big tool for me in all areas of life that I really would have liked to have sooner. So if you think it could be you, the earlier you look into that, the better, like financially, emotionally, everything. So if you are curious after this, reach out to somebody, one of the orgs, one of us, for whatever you need to, like, get the process moving, because it is worth it for sure.
Thank you for that. Sheilah?
Yeah, I think one of the things I think a lot about recently is the idea we have kind of this narrative that some people are just treatment resistant, right? And I think what we found at the school I'm at, and what I found through my advocacy work, is really that if you're treatment resistant, maybe you just haven't found the right treatment, right? And so I've been thinking a lot about that, because as doing this work, and the more people kind of look for these connections into the body and they start to find healing, like, everyone's worthy of healing. Like, you just deserve to feel better, and we're all worthy of feeling better. And I think being resigned to kind of a life of chronic symptom management, if things aren't working, it's worth exploring. If you realize you meet this criteria, even if it's long ago, I think, to Elise's point, and my kids actually got the opportunity to really heal and thrive and live. So I think it's worth it. And there's a great community of people out there. I think you can see it in the chat. People are offering resources, and the PANDAS community is really amazing. And we just want to help each other, because everyone deserves to get better.
Thank you. Dr. Tang?
I think they hit the most important points. I'm still just kind of cruising through this chat and seeing a lot of frustration with school districts, doctors. I apologize on behalf of doctors. I really am sorry if you were treated badly. But I would just say to the parents who are dealing with this, and to the children and the young adults who are dealing with this, that you just keep going, just keep looking. And if you don't find what you need, you just have to keep putting one foot in front of the other, and you will find your answer and the way to feel better. I see a lot of people going through some financial issues where they're paying big bills for maybe stuff that wasn't so great. So there's always that piece. Be careful, but keep looking.
And I would just say, trust your gut. Like, truthfully, like, it can't hurt to look. I mean, it might, sadly, and like when you tell your story, I feel like financially it might. Sometimes.
Financially, it might hurt a lot to look, but like, still worth it.
Yeah, but it can't hurt. Like, it's and I think it's worth exploring, for sure.
There's definitely a lot of follow your gut.
Follow your gut.
I when I'm talking to parents, I'm like, well, what does your mama bear or papa bear tell you? Like, what do you think? Does this ring true to you when you read this list? Does this make sense, or does it not kind of fit? Like, you have to sort of follow your heart. Nobody knows your child better than yourself.
Yes.
Mm-hmm. Thank you for that. You all were so concise. We still actually have a few minutes, so I'm going to throw in one more question at you, if that's all right.
Yeah.
We talked a lot about the awareness raising that we have to do. Tomorrow is Awareness Day, and we know that there's a lot of work to do. Why is this so important, and what can we do to continue this conversation?
So if I can start, I'll start with just our current suicide numbers and our current mental health crisis. Like, we are in a real problem. We have a real crisis going on, and it's not abating anytime soon, that I've found anyway. I feel like I'm on the front lines of it. So suicide is currently the second leading cause of death. ages 10 through 24. And we know particularly in more marginalized populations, those numbers are even higher. So we have a real call to action to really lean into new science, understanding the body and brain, and really changing the trajectory of this mental health crisis so that we can help more people. People deserve to live. So
absolutely. Thank you for that.
I have some anger about this entire situation that I've been through. So if that has come through my answers, I apologize for that. But also, that is my call to action, I guess. The frontline people, like for a long time, I couldn't figure out who I should be mad at. I was mad at my parents for not pursuing more. And then I was like, my parents have no idea, like, that this was even out there. If you are a provider or an advocate or someone that comes in touch, since we're on the IOCDF platform, if you come in touch with people with OCD, it is your responsibility to learn about this illness so that you can get those people to the referrals they need. There's like a very large amount of accepted ignorance about this for some reason that like really frustrates me, because though if you're trying to help people with OCD, this is a huge component of that for some reason does get ignored. So if you're here and you've now like tapped in, I'm very happy about that. Try to get your other OCD community serving people, peers, therapists, etc. on board, because that is the front line. That's who's going to get those people to consider it, because you have authority in their lives over their health.
Well, thank you for that. And I hope you know that you've come off as passionate about something that's really important. And we appreciate that. And we're so grateful for that passion and that you're willing to share that with us. So
thank you. I appreciate that.
Thank you. Dr. Tang, do you want to take us out?
Yeah, okay. So why is PANDAS and PANS Awareness Day important? This isn't a super common disease, but I don't think it's a super rare disease either. I think we're just starting to understand what its true incidence is. And there's this number batted around that's 1 in 200. I don't think it's that high, but whatever it is, it's such a devastating disease that it is a provider's responsibility to try to recognize it when it happens, because it is treatable. And so I think that increasing awareness on the part of clinicians is important. Sadly, we still have too many people making their own diagnoses and then hunting for care. That's sort of backwards, right? It's not supposed to be that way. And then, you know, the barriers to care in this illness are so monumental, and they exist on every single level. Finding a doctor, convincing your school, arguing with insurance some more, and then arguing with insurance some more. Being treated poorly by the medical establishment, you know, just so many things that I think we need awareness on a lot of levels, because we have to push all of those barriers slowly out of the way all at once together. It doesn't make any difference if we have all these laws that will allow us to get our medicines covered, but we have no providers who are willing to take it seriously, you know, and vice versa. So we have to clear all these hurdles together. And I think that's what the awareness efforts are trying to do.
Thank you. Well, thank you all so much for being here, for sharing your expertise, for sharing your experience. This was such an important conversation, and I'm so grateful that you all let me be a part of it. Thank you to everyone in the chat for participating, for being here, for being open, for asking your questions. We have a few closing announcements that I'm going to read quickly, and then we will call it a night. So thank you again to everyone. Just a reminder that the IOCDF is a nonprofit. And if you are interested in making a donation, I will put the link up as soon as I find it. Here we go. Sorry about that. Sorry for the delay. All right. Well, thank you again, everyone. And to my panelists, thank you so much again for your experience and your time. For everyone tuning in, make sure that you're aware that next week is OCD Awareness Week. We cannot wait. We are so excited, and we're looking forward to marking that week with all of you. We have tons of great events going on. If you go to iocdf.org/OCD week, you can see a schedule of events. There's shareable graphics. There's information on our live streams that week. Tons of fun stuff going on. So thank you all again for being here, and have a great night.
Thank you.